everyone. Thank you for attending this webinar on depression and antidepressants presented by Breitbart.com. I'm very pleased to be with you today. My name is Marcy Starkman and I'm a licensed psychiatric clinical nurse specialist. My talk is going to be based on my clinical knowledge and experience, but in no way is it to substitute for medical or professional advice. I'm going to present for about 20 minutes, and during this time while I'm talking, all your mics will be muted in order to minimize any kind of audio interference. At the end of my talk, I'll open up the mics and I invite your questions. I demand your questions. I'd love to hear from you and your comments. Please don't be shy. We need your help and input to get this information out there. So let's get started. I'm just going to do a quick review of what I went over. For those of you who were here last week, you'll remember that I talked about the mechanism of depression. And in order to understand medication and how it works, we have to understand what's happening with a person biochemically. So I have a little tricky thing. Okay, in a normal person, there is a regulated amount of neurotransmitters. We need a certain amount of neurotransmitters to balance our moods. If we don't have enough neurotransmitters, like in the middle, then we get depressed. If that happens, then my last slide, or my last little spot over there, is that with treatment, it stimulates the production of the neurotransmitters that we need. And last week, like we talked about, it's serotonin, norepinephrine, and dopamine. All three of those are important in terms of regulating people's moods. Most of the time, people who are clinically depressed have a decrease in those neurotransmitters. So the point of using an antidepressant is to get them to A, produce more neurotransmitters, and B, to make sure that the brain knows to leave the ones that are there alone and to not take them back up into the nerves because the person needs them in order to not be depressed. I'd just like to review for a minute the signs and symptoms of a major depressive episode. This is what we see in someone that we call clinically depressed. Someone who's got 5 out of the 9 of these symptoms that have lasted for 2 weeks or longer. We say that they're clinically depressed and that they might possibly be responsive to antidepressant medication. So all of these, you can have a decrease in activities, you can have an increase, no pleasure from what you're doing, from your work or from your family or anything like that. Also, you can be eating too much or not eating at all and losing weight, even 5% in 2 weeks. So all of these symptoms, especially, of course, the last one, suicidal thoughts, are amenable to the biological treatment of the depression, and that's where antidepressants come in. There's lots of different classes of antidepressants. The oldest, the very, very oldest, are on the left. They were called tricyclics. They were in use as long as 35 to 40 years ago. And I need to mention, by the way, that antidepressants are not as much mood stabilizers as they are mood elevators. When we hear about a mood stabilizer, we're thinking more of something like lithium, and that's used in someone who is bipolar, that they're depressed and they're manic. They have episodes of each. These are used purely in a person who is depressed. So keep that in mind. Antidepressants are for people that are depressed, and mood stabilizers are for people who are bipolar. Right? SSRIs, they've gotten the most press, shall we say. Prozac, Zoloft, we hear about those a lot. They were a major improvement over the tricyclics, which had an awful lot of side effects. And because they had side effects, people didn't like to take them, so they stopped taking them. And we're going to talk about side effects in a few minutes. But the SSRIs came along, and one of the good things about them is that they started to, that the person could respond to the medication much quicker than they used to be able to on the tricyclics. Sometimes the tricyclics took up to 6 weeks to kick in, where sometimes people with SSRIs, I've seen them respond as quickly as 3 or 4 days. They start feeling better mentally and physically. So definitely speed of response, less side effects, easier to tolerate because of that. Also, tricyclics tend to have some negative effects on the cardiac system. So for older people, they weren't the best medication to give them because they could possibly affect their hearts, which weren't in such great shape to start with. So the SSRIs don't do that, and that's what makes them somewhat better. Older people are allowed or older people can tolerate them better. Same thing with SNRIs under that class. And the reason that they have different letters, all of these different colored bottles, shall we say, affects different parts of the brain. So if a person's got too much of one neurotransmitter and not enough of the other, the doctor will, or the healthcare professional will make sure that they put them on a medication that specifically targets the neurotransmitter that's lacking in the person. So, for example, SSRI stands for selective serotonin reuptake inhibitor. So just remember that the S part is serotonin, and the N in SNRIs is for norepinephrine. Now we come to the MAOIs. MAOIs have been around forever. They were first discovered for patients probably 50 years ago who had TB. It was a TB treatment. And when they gave it to patients with TB, their moods improved. So somebody said, wow, we could use this as an antidepressant, whether the person has TB or not. The bad news about MAOIs is that they have a significant amount of major side effects that occur if they're mixed with certain kinds of medication and certain kinds of food. So if somebody mixes an MAOI, let's say with aged cheese or Chianti wine or Dristan, cold medication, something like that, they can develop what we call a hypertensive crisis. Their blood pressure can go through the ceiling, in so many words, and they, of course, can have a stroke. So MAOs are only good in someone who hasn't responded to any of the other medications, but also who can be very reliable with taking them, is not acutely suicidal. You certainly don't want to give MAOs to someone who is extremely suicidal, because they would then know that all they have to do is take their medication and start mixing it with foods or drinks that they're not supposed to have. So they are really a last resort. They are not used very often because they have so many interactions with foods and other medications. But that being said, they are effective. I have seen people respond to MAOIs when they were not responsive to any of the other classes of medication. So it just depends. You don't see them very often, though. Those are, the names of those are Nardil, Parnate. Those are a couple. And again, they're not used very much because of their side effect profile. And then newer combinations, those are meds like Cymbalta is one. And these newer ones, Pristique is another one, Vyvanse, you see them advertised on TV, right? All the time they say, oh, here's the latest and greatest antidepressant. But sometimes the oldies but goodies work the best. Just because it's new and great doesn't mean that it's going to be the most effective. But the good thing about the newer combinations is that they may target more than one problematic area of the brain in terms of neurotransmitters. So it might not only help like on serotonin, but it might also get some of the other neurotransmitters going. So that's why they may be tried. The rule of thumb is most of the time is that we start low dose and start slow. So start low, go slow before we raise it. Some people are very sensitive to these medications, and I'm going to talk more about that as we go on. But they are, by the way, lifesavers. If someone is clinically depressed and they're able to get on a medication that helps alleviate their depression and they start feeling better, that's great. That's what we're looking for. Possible side effects. The one on the left with the cartoon, that's what the TV would have you believe, right? When you see commercials about antidepressants. But the reality is, on the right, I'm going to go through each one of these. When I say dry as a bone, that's what they taught us in nursing school to kind of remember the major side effects. And dry as a bone used to be true, is true mainly with the tricyclics. When they say dry as a bone, it means that the person might have urinary retention. They might not be able to pee. They might get constipated. That's another problem. They may also have blurred vision, which you get as a side effect. So when they say dry as a bone, person complains terribly of having dry mouth or having blurred vision. And these side effects are things that sometimes make people stop taking their medication because they don't want to deal with the side effects. Appetite and weight changes. A lot of people hate these meds because they increase their appetite. And if you have, let's say, a woman with an eating disorder, and then they put her, and she's also depressed, and they put her on an antidepressant, and now suddenly she's hungry all the time and she starts putting weight on, she's not going to want to take the medication because she wants to stay thin. So that's an issue. Blood pressure changes, either up or too low. Some people, it makes their blood pressure too low and they can't tolerate the medication. Either it wakes them up, so we tell people to take antidepressants in the morning because it does. Some of them do have a tendency to kind of agitate you a little bit, not agitate you in an angry sense, but just get you more motivated than you have been, because decreased motivation is something that you have with depression. So the person may have insomnia, and that's my first question that I ask when a patient says to me, you know, ever since I went on that antidepressant, I can't sleep. And I'll say, what time of the day do you take it? And when they say they take it at bedtime, right away, you know, I talk with their provider and make sure that it's okay for them to take it in the morning. And most of the time, that's when they should be taking it anyway. Or especially the old tricyclics made people too sleepy. They were knocked out. Yeah, they were less depressed, but they couldn't wake up. They didn't want to get out of bed. They were zonked. And so that wasn't good either. So it could go either way. Sexual changes. In women and men, we may see the inability to reach orgasm. Men may have an inability to have an erection, and if that's the case, well, you know, think about like a young, any guy, he's going to not be too thrilled about the fact that the antidepressant has caused that to happen. So not all of them do that. Sometimes it's just a question of one being switched to another one. One has that effect, another one doesn't. They can also give another antidepressant to help decrease the problems with the sexual changes, and that happens. But the thing is, sometimes doctors don't ask about that, and sometimes people don't just raise their hand at the doctor's office and say, and by the way, I can't get an erection, or by the way, I can't have an orgasm anymore. They just keep quiet and they stop taking their medication, or they think that the changes in their sexuality are related to the depression, when in fact the changes are related to the medication. And I know of one couple that basically their marriage broke up over Prozac. And this was many, many, many years ago, 20, 25 years ago. And the woman lost all desire for sex. And of course, the husband figured, well, she's depressed, so we have problems in the marriage. And they went to a marriage counselor and everything. But at the time, nobody put two and two together that that particular medication was causing her to decrease her interest. So they ended up getting a divorce because they couldn't resolve the difficulties in therapy. And therapy is not going to help if you have physiologic changes related to medication. So that was a kind of a very sad story. People can also feel more anxious and restless. I'm going to talk to you in a few minutes about the potential for violence and an increase in suicidality. Now, the question is, as far as that goes, does a person become more suicidal when they're on an antidepressant because of an effect of the medication? Or do they become more suicidal because maybe 2 weeks ago when they were depressed, they didn't have the motivation or the energy to hurt themselves or to try and kill themselves? And now that they're on an antidepressant, they feel better, they have a little more strength, they have a little more energy, and that does make them at risk to kill themselves. So that's something that we watch for very carefully. Someone who, and you should watch for as well, that someone who's been very, very depressed and that suddenly they're doing better, like overnight, and they're feeling better. It could be because in their head they've decided what to do, that the answer to all of the problems is to kill themselves, and now they have the wherewithal, shall we say, to do it. So that's definitely something to think about. And hypomania. Hypomania is not full-blown mania. Mania is a whole nother discussion, but a manic person is like, they're acting like they're high on drugs, but they're not. It's not because of drugs, it's because of their neurotransmitters. And in the case of mania, they have too many neurotransmitters. Depression is too little, mania is too many. And so they need medication to bring them down. But then the problem is, once that happens, they get down, 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 and they may become very depressed as well. And sometimes people are not diagnosed as manic or hypomanic. Hypomanic means they're not full-blown manic. They're still able to maybe work and function and not get themselves into too much trouble as a result of their mania. But when someone is on an antidepressant and they've never acted like this before, like they've been put on an antidepressant, and 3 days later, they become what we call hypomanic. They have a lot of energy, they're staying up all night, they're involved in all kinds of projects, they're hypersexual, they're spending money. In a way, that's a good thing, because then that tells the provider, the physician or the nurse, or whoever's caring for this person, that in fact the person is bipolar instead of just depressed. And it's like the good news and the bad, the good news and the bad news. Good news is, well, you're bipolar, or the bad news is you're bipolar. But at least if you're bipolar, then there's medication specifically for that as well. And that might not be diagnosed any other way than having this totally opposite reaction to antidepressants. So that's something else to think about. When I say don't go cold turkey, people get fed up with these medications. They do have side effects. Every medication has side effects. Aspirin has side effects. But then somebody will say, I've had it. Every little thing that happens with them, they tend to blame on the antidepressant. I'm exaggerating, but they'll say my eyelashes are falling out, and it's because of the antidepressant. My hair's falling out. My stomach's grumbling too much, and then they just decide to stop taking the medication. 1, 2, 3. You cannot do that. With antidepressants, they have to be tapered off. They have to be weaned, because if they're not, the person can actually have withdrawal. Not the same kind of withdrawal that you see on hard drugs, but they can have withdrawal symptoms like shaky hands, electric shock-like sensations in their muscles, dizziness. They just don't feel well. They feel almost like one described to me as if like a truck hit them. And it was because the antidepressant was stopped too suddenly. So they do need to be tapered off. So I always tell my clients, don't go cold turkey. Just don't wake up in the morning and say you're not going to take it anymore. If you're on 20 milligrams of something, then you need to come down maybe to 15 for a few days, and then down to 10 until you get off it, and you won't experience those withdrawal symptoms from not taking it anymore. Pregnancy and antidepressants. Keep in mind that antidepressants cross both the placenta, so a mom who's pregnant, the meds, if she takes them, do get passed on to the baby, and the same thing with breastfeeding. If she breastfeeds, the antidepressant does go into the breast milk, and the baby gets it. A small amount, but the baby still gets it. There's a lot of controversy about whether or not a breastfeeding mom or a pregnant mom should take antidepressants at all. But if someone is suffering, the benefits have to, the benefits have to outweigh the risk. If, like the quote says, which is worse, that the mothers might pass on a little bit of the antidepressant to the baby, or the baby has a miserable, unhappy mother who can't be there for the baby. And there's studies where they show even how a mom not smiling at her baby over an extended period of time can cause a lot of stress and anxiety, even in an infant. So there are ways around that. There are things that moms can do when they're pregnant and when they're breastfeeding, and I'll give you some good resources at the end. It's not a total no. And of course, the longer these medications are out, the more evidence there is. There are some that are more safe than others. And the woman really has to work with a provider, healthcare provider who knows what they're doing to help her with that. Healing with depression without meds. People will say to me, I don't want to take medicine. I don't want to take medicine. What should I do? Well, here's a list of things. However, given this list, if you are suicidal, if you cannot function, if you cannot get out of bed, if your relationships are deteriorating, all the diet in the world is not going to get you out of that kind of depression. I think that this really has to be evaluated, not just by yourself, but with a provider. A lot of mainstream psychiatrists are now doing more natural things first, depending on what's going on with a person. Supplements, herbs, vitamins. I don't have acupuncture on there, but that's something. Also, what I found fascinating when I was preparing this is that now there's a new theory, and it's still being researched. It's not engraved in stone by any means. There's not enough information about it. There's not enough studies. But probiotics, that depression happens because of inflammation, that there's a tie between the gut and the brain. That's very, very interesting. That's very, very encouraging because they're saying if we can fix the bacteria in the gut, then we can fix the depression in the brain. That's down the pike a bit, but there are studies, and they are actually being funded by the National Institute of Health, so it's not something that someone just came up with. Most of these, like fish oil, SAMe, supplement low levels of those things in the person's body, and that could be a whole other lecture. 5-HTP is a precursor for serotonin. Serotonin is that happy chemical, so if you don't have enough 5-HTP, you're not going to have a lot of that happy chemical. So by taking the 5-HTP, it increases the amount of serotonin, and that also helps. But again, this has to be weighed with a healthcare professional. This shouldn't be something that you just go to the drugstore and say, oh, I think I'll try that this week, or try this. Also, some of these you cannot mix with mainstream antidepressants. So it really, really needs to be monitored by a professional, either a naturopath or an integrated physician, something like that. Substance abuse, I'm going to just ask you the question. This is the question: does your substance abuse cause your depression? Bottom line, if your substance abuse causes your depression, then if you stop abusing the substance, you won't be depressed. I mean, it sounds so simple, right? But there is some truth to it. The major thing is point number 2 on here, that one reason that many, many, many patients don't want to take antidepressants is they're afraid they're going to get addicted. The difference between antidepressants and street drugs or other illicit drugs, you don't need to keep taking more and more to get the same effect. Like someone who is addicted to opiates has to take more and more and more to feel the same way they felt last week. Whereas antidepressants, that is not the case. Even though there's the withdrawal, it's not a psychological withdrawal. It's and it's not with every antidepressant. Some people are on antidepressants their whole lives, and they do not get addicted to them. So I do need to clarify that. Antidepressants and violence. That's another thing. A lot of bad press. Oh, he went and shot up the school because he was taking antidepressants. The studies have shown that for the most part, there was very little correlation between antidepressants and violence towards yourself in terms of becoming more suicidal or becoming violent towards other people. That being said, the FDA has put out a black box warning saying that people under the age of 25, there is a small, I think the figure I saw was a 4% risk that there may be an increased risk of suicidal thinking and behavior. But again, it goes back to someone become more suicidal when they're feeling, you know, a little stronger and a little more motivated, a little more organized. That we don't know. These kinds of studies definitely raise more questions than answers. And a decision should not be made whether to take antidepressants or not based on sensational information. It really does need to be weighed out. And the person needs to be under really good medical supervision when they're on medication. I like this. I'm going to end with this. I saw Ellen and her quote, and I thought it was so true. All the commercials on TV are for antidepressants, and they get you right away. Are you sad? Do you get stressed? Do you have anxiety? And then she says, yes, I have all those things. I'm alive. And I think one of the tendencies is the other way is that, you know, life is stressful. Life does make us anxious, but yet we wouldn't be a human being if we didn't react to them. The problem comes in when you can't function anymore, when you're so paralyzed with stress, you're so paralyzed with depression, you're so paralyzed with anxiety that the things that are important and good in your life don't feel that way anymore. So doesn't mean you need an antidepressant. Maybe sometimes you need to quit your job, or you need to get out of your relationship. It's a whole bunch of things. It's just not one thing that we can put a finger on. But I think she kind of put it very well. I have some resources here for you that kind of address all the different things that I was talking about today. Please feel free to go. They're really good, very interesting websites that I did get some of the information for my talk from. And all of these are, I do need to mention, all of these are scientifically based. Interestingly enough, there was one website that had, and I'm not going to mention it, but it was a website that talked all about the side effects and the terrible things that happen when you take antidepressants. And I'm reading this and I'm getting ready to, you know, share this information with you. And then I saw where the website was from, and I thought, that's interesting. So I typed the address into the computer, and it happens to be a very non-scientific anti-psychiatry group. I'll just put it that way. And they have information all over the internet about how terrible psychiatry is, how terrible antidepressants are, how poisonous, and how they're causing the ruination of society. So all I'm saying to you is, you know, I was kind of glad I looked up to see where that information came from, because at first it looked very convincing. Read things that are scientifically based, not just opinion-based or belief-based. You've got to have the scientific evidence. And that's it for me. We're going to open up the mics. If you have any questions, please feel free. Here's your chance. I'd love to answer your questions.
I have a question.
Sure.
For someone that is on antidepressants, and
yes,
say they were diagnosed with, say, cancer,
okay,
and they've started treatments, chemo, radiation, and all that, would they still be able to continue the antidepressants, or there would be a conflict with medications going on? And how would you treat that?
Okay, well, there's always a potential. Let me start by saying there's always a potential between a conflict with medications, you know, but the thing is, you know, some medications have less conflicts than others. And one thing you don't read about scientifically very often are chemo drugs and antidepressants. As a matter of fact, many cancer patients are on antidepressants and receiving chemo at the same time. They don't interact with each other or cause harm. And, you know, let's face it, when somebody's got cancer, they may get depressed, and they might need that antidepressant because they now have a biological depression. So they just have to be, I like to see people on antidepressants seen by a specialist in the brain, which would be a psychiatrist, because I think psychiatrists really know a lot more about what they're doing with medication than other doctors who don't use them very often.
Thank you.
You're welcome.
Marcy, have a question.
Okay, there's my girl. Hi, Valda.
Hi, how are you?
Good. Go ahead.
In a case where you may have someone that has postpartum depression.
Yes,
And the only thing that is working for them is possible medications.
yes.
Wouldn't it be better for them to use the medication then and try to, but they have started saying like breastfeeding their babies or whatever,
Mm-hmm.
take that medication and probably try to wean the baby from the breast and give them like a bottle or something like that, some sort of formula.
Mm-hmm.
But then if the baby is not, cannot take the formula, what do you do in a case like that?
That's a great question. All right, it's got several parts to it. First of all, if somebody weans cold turkey, she's breastfeeding today and then decides tomorrow she's not going to breastfeed, that can precipitate more depressive symptoms, right? Because of the change in hormones.
Okay.
When she stops breastfeeding, suddenly the hormones go down, and that can make her more depressed. So I always tell my moms, don't go cold turkey with the breastfeeding. There's also something called, there's a technique called pump and dump, where the mom can actually pump her breasts and wait, then they're empty, and then wait until they fill up again, and then feed the baby when there's the least amount of antidepressant that's transferred from the breast milk, to the baby. I think that what trumps everything is, I hate to use that word now, but what overrules everything is a baby needs a happy mother, right? Without a happy mother, it doesn't matter. So whatever it is, there is some kind of formula for every baby, so I know sometimes moms I knew one mom, she had to go through like 3 different formulas, unfortunately, to find one that agreed with the baby, but that's important. But it was more important that the mom stopped breastfeeding because she couldn't stand it. She was crying, and the other side of that is if she stops breastfeeding, then she feels guilty. I'm a bad mother because I'm stopping. So then we have to deal with that. So the combination of medication and therapy is really the best for a new mom like that.
Oh, okay. All right.
Okay.
Thank you.
You're welcome.
But that pump and dump sounds pretty feasible to me,
Yes, it sounds terrible, but it is a good technique.
Yeah.
And again, some of the antidepressants have been out there now long enough that they know that they're pretty safe for the baby. Some are more safe than others, so the doctors are more willing to give a new mom those. Or the mom might take the antidepressant in the morning and not feed the baby breast milk. She may do the pump and dump thing after that.
Okay. All right. Thank you.
You're welcome. More questions?
I have a question. What if someone is prescribed a medication, hypomania?
Yes.
And once they start taking it, they're really hypo. And what can they do to bring them down to some kind of normal? Would they just go cold turkey, or would they adjust the medication and make it a gradual?
That's a good question. If somebody becomes hypomanic, it depends on what symptoms they're showing. I mean, some hypomania might just be that the person has a lot more energy and a lot more activity and isn't really getting into any kind of trouble. So at that point, the doctor would reassess the person and say, this probably isn't a good medication for you. And it would depend on the individual doctor and the person, what symptoms they had and everything, whether they would wean them down slow. Chances are they weren't on the medication long enough to develop withdrawal, so it probably could be stopped pretty quickly, because if somebody's going to get hypomanic, it's going to happen really fast.
Okay, thank you.
You're welcome. Anybody else have a question?
I have a question.
Okay. Hi, Wayne.
Is there any truth in the idea that antidepressant medication can cause hallucinations?
You know something? I wouldn't say yes or no to that, because people have what we call sometimes just unusual reactions to medications that they might be the first person who ever had that reaction. I have not heard of many cases of someone who develops hallucinations as a result of being on an antidepressant. But by the same token, it's possible. I mean, we're talking about medication that's affecting brain chemicals, right? And if the person's never been on those medications before, they may develop a reaction that's not common. You know, some people can't take aspirin for whatever reason. They take it, but for whatever reason, it doesn't agree with them in a way that, you know, you may not have ever heard of before. It's very individualized. So I can't say for sure. Now, again, sometimes when a person is given an antidepressant and they become hypomanic or even fully manic, they could have hallucinations as a result of being manic. Sometimes hallucinations and mania do go hand in hand. Very individualized.
I have a question.
Okay.
Assume somebody didn't want to take antidepressants, but also assume this person is or was depressed or very sad. What would you tell someone who was apprehensive to begin taking antidepressants because they might think, oh, well, yes, it might make me feel good, but then I'm going to be stuck and I'm going to have to take them forever. And then if I stop taking them, then I'm going to be as depressed or maybe even more depressed. What would you say to someone like that?
Great question. I think I would, you know, if that person came to me, I would, first of all, try and explore the meaning of what they're afraid of. You know, maybe there's somebody in their close circle, their family or their friends who had a bad experience with antidepressants, or maybe it's something they saw on TV. You know, when you just see any commercial for any drug on television, what do they do at the end? They read you, you know, 150 different side effects. By the way, if you take this, this will happen, this will happen, this will, like that cartoon. So is there fear coming from that? I mean, it's an individual choice. You cannot, you know, you can't commit somebody and force them to take an antidepressant. But you explain what the risks are of taking it, and then you explain what the benefits are. And many times with my own patients, when I explain, like especially with new moms who are depressed, when I explain, you know, I'll say, I've had other moms who were just as depressed as you, and they didn't want to take medication. And then once they did, their whole outlook changed. It's like when you're depressed, it's like having a gray screen over your eyes and the whole world looks gray, and you take the antidepressant and it helps you, you start to feel better. It's not a lifetime sentence. But if you had a chemical, I use this example all the time and it seems to work. If you had, let's say, there's no difference in depression than, let's say, diabetes, right? If you had diabetes and you had to take insulin every single day for the rest of your life to stay alive, even though it's not the greatest thing in the world, you're still alive, you feel better. If you didn't take the insulin, or if the insulin wasn't available to you, you would be suffering and you'd have all kinds of other issues. So when I use that comparison many times, that helps people feel better. I say, if you had a broken leg, you know, would you take pain medication for it to feel better? Well, depression is like a broken leg at the brain in some ways. And just sometimes it takes a lot of counseling and exploration as to why the person, as long as they're not acutely suicidal, Joe. If they're acutely suicidal, that's another issue. I mean, they need to be cared for and have 24-hour supervision. But if it's somebody who's just unhappy and they're kind of going back and forth about it, or they're concerned, I would try and explore those concerns and you know, say, look, the other thing is, if you don't like it, try it for a month. Let's see how you're feeling in a month. And I've told some patients who've been on 20 different antidepressants, no joke, I've said to them, look, you know, thank goodness there's so many of them. Maybe 20 didn't help you, but number 21 is going to be the right one. Sometimes we have to go through 20 to get to 21. It doesn't exactly make them feel better, but that's the truth. I mean, you know, it just depends. That right med for the right symptoms, the right biochemical imbalance. Sometimes I knew people who didn't respond at all to tricyclics, and they were miserable and depressed until Prozac came out. And then when they were prescribed Prozac, because it worked differently than the old ones, they started feeling less depressed. They just hung in there because they didn't want to suffer.
Thank you very much.
You're welcome. Does anybody have a good story about, you know, or a good example of someone who they know was helped by antidepressants?
Marcy,
The big bag. Carry it in. Carry it in. Carry it in. I need to come in.
Also, like I said last week, we just have to tease out, you know, we have to tease out that what's really going on is a biological, biochemical depression, and that there's not some other cause for it. And the way the mental health care system is right now, sometimes it's hard to get that really good diagnosis. I mean, if your life is, if everything in your life isn't going very well and you're depressed, some things have to change, not only with antidepressant medication, but with your life too. And some people aren't able to do that. Or they don't know how to be any other way but depressed. Anybody else?
to you. What is the possibility of getting the right, the correct regimen for someone on meds, whereby you're trying to get them on the correct regimen, but you're not sure if it is going to counteract with the other that they've done so far. How do you go about getting them stabled on the correct medication?
Let me make sure I understand. So the person's on more than one antidepressant?
No.
Oh, go ahead.
No. Say for instance, like the person, when they're taking maybe the SSRIs or whatever, and they have like suicidal thoughts and stuff like that. And then you want to make sure that they don't have those types of thoughts, and you try them then on another type of regimen, and they may have tendency to have maybe dry mouth or can't go to the bathroom or something like that.
Yes.
How would you go about getting them on the correct regimen so that they would not have that effect whereby one would counter the other?
Right. Okay. Well, some of those side effects that you mentioned are either like the dryness, they're either related to the dose of medication that the person's on, you know, how many milligrams, right? Or I just lost my train of thought. Having a moment here. Anyway, it would depend. Some of those side effects abate after a few weeks, like they're temporary. They may be problematic the first 3 weeks or month that the person's on the medication, but after they're on it for a while, they get used to it, or they learn how to deal with it. Dry mouth, there's mouth rinses, there's chewing gum, there's hard candy, there's things like that. Constipation, there's certainly things we can do. I mean, depression is much more life-threatening than constipation. We got lots of help for constipation, but if it's helping their depression, you know, but they're constipated, let's take the good and work on the bad. Work on the constipation, which is much easier to deal with than the depression is.
Okay.
I guess. So, sometimes it's trial and error, but the more questions that the healthcare professional asks the person, and the more information that the person shares with the healthcare professional, the better the outcome's going to be.
Oh, okay. All right. Thank you.
You're welcome. Anybody else? Okay, well, I thank you for coming back this week to hear all about antidepressants, and I look forward to starting off your weekend with you again next Friday, okay? Have a great week, and thanks for listening. I appreciate it. Bye for now.